And I think still a
I'm
national registered
I'm
paramedic.
recertifying my national registry.
Yes, from Colorado. And he's done an emergency medical school after that, emergency medicine residency, and a fellowship in EMS. And Marlo has been working with Mark and I for the last couple of months now. And he is he will be, I guess you guys can refer to him as an assistant MPD. And I've got him primarily working on education and quality assurance. So many of you have already had the joy of receiving a little missive from him in the form of a review of a chart. We're reviewing all Code 3 charts now and all the index charts in pretty much real time. So you'll know within 1 or 2 days of any protocol issues, etc. But we're trying to keep on top of these things. And you get positive feedback too, which is, I mean, if you deserve it. Yes. So, at any rate, Dr. Mocht will be giving the primary lecture today, and I'll be finishing up with case reviews. So, welcome, Marlo.
Thank you. I mean, we have some people listening remotely through GoToMeeting. I'm going to get that started. And I will look for any questions. For the people who are listening remotely, I'm going to be trying to stay roughly in this area, which is hard because I tend to wander. Can you hear me clearly in the back? Okay. So let's do a couple of road rules, and then we'll talk about abdominal and pelvic trauma. So no one got into EMS because they had a great attention span, and I'm no exception. And so I don't think it's fair to ask you to listen to me for more than 50 minutes without a break. So I'll make sure we're taking a break. Please interrupt me with questions that come up throughout the lecture. I'll repeat the question, and then I'll ask that. I will look for questions from the remote people as well. And then finally, I have put evaluations out at the back of the room. Please return them to the back of the room. I'll be back talking in November, and I want to make this as useful a session for you as possible. And so I really want your honest feedback about what's working about this and what's not. So with that, let's start thinking about a call. So picture it's about 1 o'clock in the morning, and you're dispatched on a single car crash on Patton Parkway just under I-205. One car went into a retaining wall. There's a 54-year-old male in there who's got slurred speech. As you open the door of the car, there's some beer bottles that are falling out. And you can see that he's got an airway. He's breathing rapidly, but has equal breath sounds. And he's got a thready tachycardic radial pulse. And here are your initial vital signs. So what I want to ask you is, what is going to determine whether this patient survives or dies? Trauma team. So getting the trauma center. What else? Extrication. And what about the extrication? Yeah, rapid extrication. What else? Yeah. You don't, particularly with the pelvis, you're not going to want to do extra manipulation, and we'll talk about some other things that you can do that can help. And it's ultimately, if this person dies, what's going to be the cause of death? Hemorrhage, bleeding. So this is the essential problem that we face in abdominal trauma, and this is why the EMS intervention can be so critical. So this is from the Trauma Combat Casualty Care course, and I just think they do a very good job of explaining this. So this is the normal adult blood volume. Picture 5 liters of blood. And now, it's not great to lose half a liter of blood, and it's worse to lose a liter of blood. But when you get down 2 liters, you really get to a tipping point where, because of the blood loss, the patient starts to become more acidotic, the blood has a harder time clotting, and so then you get more bleeding. And then even if they're in the operating room, it can be harder for the surgeon to control the bleeding because everything just kind of oozes. And so we are trying in EMS to keep this patient on the right side of this tipping point, to keep this patient where he has salvageable, correctable bleeding, and to give this person a fighting chance. So there's teaching and surgery. And if you think like a surgeon, think, what body cavity do I need to enter to fix this problem? And that's the way a surgeon's thought process is structured. And the way they talk about this is classically, they talk about the floor plus 4 more. So there are 5 spots where patients can lose enough blood to die. In the thorax, in the peritoneum, the retroperitoneum, the pelvis and the femur, and then on the ground. And so of these 5 areas, 3 of them we're talking about today, and the last one, the ground, you in EMS are really the only people who can properly assess that and give the surgeon some idea what's going on. So what we're talking about today is the core of how you keep people alive when they have trauma to the abdomen and pelvis. And we're going to talk about what the signs are of bleeding in the peritoneum, bleeding in the retroperitoneum, bleeding in the pelvis, and then how to manage those things. So what works are the things that you've brought up. So it's identifying early that this is a significant abdominal injury. Now, this case is more straightforward, but we're going to talk about some cases where that's hidden, where abdominal trauma is kind of a sneaker diagnosis. And I'm going to give you some clues for things that you can use to pick this up. We're going to talk about rapid packaging and transport to a trauma center. And getting this patient to a trauma center in a rapid fashion is critical. I work at Salmon Creek. I love working there, and I think it's a great ED. But if I'm going to crash, please take me to Southwest, because this is very much a team sport that includes the initial EMS assessment, includes the emergency physicians and trauma surgeons on the front side, and then ultimately includes a lot of rehabilitation specialists, physical therapists on the backside to get someone through trauma. And then finally, we're going to talk about the specialized assessment and treatment of pregnant patients, because they're at risk for different complications from abdominal trauma, and there are different things that you have to do because the patient is pregnant and because you're essentially dealing with 2 patients. So how are we going to get there? We'll talk about the anatomy and injury patterns that are relevant to abdominal and pelvic trauma. We'll talk about the key factors in the assessment. We're going to review the management, and then we'll talk about the assessment and management of pregnant patients. So first, anatomy and injury patterns, because the abdomen is capable of amazing things. Okay? So we're going to talk about the boundaries of the abdomen, the key spaces, the peritoneal space, the retroperitoneal space, and the pelvic space. And then we're going to talk about specifically things that you see with injury patterns. I'll make some brief asides to talk about hollow versus solid organs, and also to talk about pediatric patients. So when you're faced with a patient, you have to consider abdominal injury in anything between the nipple line and the groin. So why is that? The diaphragm is the upper boundary of the abdomen, moves up and down in the torso, which allows for respiration. So when you're expiring, the diaphragm raises up to the nipple line. And remember that injury to the diaphragm, because it's an essential muscle of respiration, can cause respiratory compromise. So you can see patients that have respiratory problems from abdominal trauma. So these are the 3 specific spaces in the abdomen that we're going to be talking about. So the biggest space is the peritoneal space. And so that's what I'm outlining with my pointer here. This is the peritoneal space that houses most of the abdominal organs. Then you have the retroperitoneal space, which is relatively much smaller, but houses some incredibly vital organs. And then you have the pelvic space, which includes the bladder, the female uterus, and the rectum. And we'll talk about the specific problems that go with injury to and bleeding in the pelvic space. Any questions about those spaces before I move on? So the peritoneum is a serous membrane that covers most of the abdominal, surrounds the interior of most of the abdominal cavity. So it covers the small bowel and some of the abdominal organs. Part of the reason this is important is that, unfortunately, in EMS, sometimes we're looking straight at this. So when you see a violation of the abdominal wall, you see this kind of yellowish material that's overlying the abdomen. This first part is called the omentum. It's this part here that kind of hangs down in front. People say almost like an apron. And depending on how nutritionally overzealous you might be, this has varying degrees of fat attached to it. And then as you lift that back, then you see the intestines. Why do I mention this? Sometimes you're asked to transfer patients that have a positive FAST exam. And so I just want to explain what this is so you understand. And I think this gives a highlight for why this is important. So many times you see a trauma patient come in and the emergency physician starts doing an ultrasound. What is the FAST exam? It's the focused abdominal sonogram for trauma. And it's looking in these 4 spots for signs of free fluid in the peritoneum or around the heart. So when you have a positive FAST exam, that's free fluid in the peritoneum. So this is the liver here, this is the kidney, and this black stuff here is free fluid in the peritoneum. Now, in the setting of trauma, we assume this is blood. If you were to do a FAST exam on someone who has ascites, you'd see the same thing. But in the setting of the trauma, we assume this is blood. And so this means that there's a fairly significant amount, usually at least 500 milliliters of free fluid in the peritoneum. And so that in the setting of trauma, we assume this is significant abdominal hemorrhage. This doesn't show you the peritoneum. It can give you some idea of the pelvic space. Sorry, it doesn't show you the retroperitoneum. It can give you some idea of what's going on in the pelvic space. But that's what we're looking for when we do this initial ultrasound. So now the retroperitoneal space. Much smaller, but houses critical organs. So to orient you to this, we're looking at a cross-section of the patient. What's in white here is the peritoneal space. And then this back here is the retroperitoneal space. So you can see we have the kidneys. You have the duodenum, which is the first part of the small intestine. You have the pancreas in the retroperitoneal space. You have a portion of the colon. It's down lower than this cut. And then you have the aorta in the inferior vena cava. And so this doesn't communicate with the peritoneum. This is a space by itself. And the reason that this is important is that when you're pressing on someone's belly and they're really tender or they're getting distended, that's what you're pressing on is the peritoneal space. But someone can have significant life-threatening blood loss and have a fairly normal abdominal exam because they can be bleeding into the retroperitoneal space. So a little bit more detail about the vessels. So in this space, you have big red, the aorta, which comes down into the iliac arteries. And the aorta along its course gives off the blood vessels that support the spleen, that support the kidneys, and that support all the abdominal contents. And then you have the inferior vena cava that essentially follows it. You have iliac veins come back into the inferior vena cava. This spot here where the aorta splits is generally about the level of the belly button. Then move into the pelvic space. So in my first draft of the slide, I had these labeled, but I thought that was kind of overkill. So you have the female pelvic space, and so you have a hollow organ in the uterus. You have the ovaries here, and then the bladder right next to that. And then, obviously, as men, we're unfortunate enough to have these major organs outside of the body and vulnerable to trauma. Why is pelvic bleeding so life-threatening? When you look at these vessels as they come down, my goal with this slide is not to ask you to memorize all the names of all these arteries and veins, but just to look at the slide and see how closely tied all of these arteries are to these bones. So when you have pelvic fractures, you can have bleeding from the bone itself, but you're also very likely to have disruption of some of these arteries or veins that lie right alongside the bones. That's why the most effective therapy for pelvic bleeding is for an interventional radiologist to go in and to put a coil into usually one of these arteries to stop the bleeding to that area. But that's why you can have such significant bleeding in the pelvis. And so you can picture here's an unstable pelvic fracture. Normally this pubic symphysis should be right close together. This is what we call an open book pelvic fracture. And so those are patients that are at risk for significant bleeding. You're also at risk to other bad things with pelvic injury. So in addition to the life-threatening hemorrhage, you can have injury to the ureters, the bladder, the urethra, female genitalia, prostate, rectum, and anus. All kinds of bad things. And this, so this is something that you may see as you're getting your patient naked for packaging, but this significant ecchymosis here is a big clue that there's pelvic bleeding. Okay. So now I'm going to move on to talk about solid and hollow abdominal organs, and we'll talk about why that's important, because they get injured in different ways. So I couldn't find one single picture that had all of the solid abdominal organs on it, so I put them up here roughly in the way they would be situated if you were looking at a patient. So in the right upper quadrant, you have the liver, which is responsible for detoxifying blood. The liver also does glycogen storage, and it's the biggest solid abdominal organ. Then you also have the pancreas, which releases digestive enzymes. There's a saying in surgical residency that just because of how long it is and how tiring it is, that you never stand when you can sit, never sit when you can lie down, and stay the bleep away from the pancreas. Because the single way you can do the most damage if you're inside the abdomen is to nick the pancreas, because they have these really powerful digestive enzymes that can essentially start eating the abdominal contents. It's almost like the process of making soap, because it acidifies these things, and someone who has really bad pancreatitis can have acidification of the abdominal contents and serious problems as a result of that. And then you have the spleen, which collects the red blood cells here. And as all of these solid organs are, it's generally a stalk where you have an artery running in, a vein running out, and so a pretty rich blood supply. So here's the spleen in the left upper quadrant. And then you have the kidneys that are responsible for regulating the osmotic balance, for controlling the excretion of salt and water. And again, you have artery running in, vein running out, a really rich vascular supply. And then you have the ureters that run out from the kidneys to get rid of the urine. Any questions about solid abdominal organs? And then you've got the hollow abdominal organs. So the stomach leading into the small intestine, the large intestine. You've also got the gallbladder in the right upper quadrant, and then the urinary bladder, and then the uterus. So why is this distinction important? So solid organs are highly vascularized because of that stalk of vessels that's running into them. So they have the potential for massive bleeding. Generally, if you're going to bleed to death, you're going to bleed to death because you have some kind of injury to a solid abdominal organ. Hollow organs are dangerous because of what they contain. So moving from the stomach down, you have gastric acid in the stomach, you have undigested food. Moving down into the colon, you have stool. All of this stuff is contained in a hollow organ because you don't want it loose in the abdomen. And it can cause all kinds of problems, particularly sepsis, if this is loose in the abdomen. So the people who have trauma to solid organs tend to die fairly quickly because of hemorrhage. People who have damage to hollow organs tend to die later on the course of days to weeks because they have sepsis from spillage of these hollow organs. Far and away, the biggest cause of death from abdominal trauma is the bleeding, the damage to the solid abdominal organs. A couple notes about pediatric patients. So they have poorly developed abdominal musculature, smaller diameter. The rib has a lot more cartilage in it, and so it can transmit injury to the organs beneath it. That's why kids are much less likely to have flail chest, because the ribs can absorb a lot of the impact, but then they can have significant damage to particularly the liver, the kidney, and the spleen, because you can transmit a lot of force to those solid organs. And then kids tend to compensate fairly well for that blood loss and will maintain normal vital signs for some time before they crash rapidly. Okay, now we're going to move on to talk about injury patterns. So penetrating trauma, you can obviously have hemorrhage, but then you can also have spillage of the hollow organ contents because you're disrupting those. The liver is most commonly injured. Why do you think the liver would be most commonly injured in penetrating trauma? Yeah, it's the biggest. It's just a big target. And so penetrating trauma is more likely to require an operation. And you can picture the damage that you can do with a knife is a lot easier to fix with a stitch than the damage you can do with blunt trauma, where you tend to have a bunch of different things injured in different spots. So with blunt trauma, you're not going to have those same visible signs of injury. The spleen is the most common thing to be injured. Why do you think that is? So it's right by the rib margin. Why else? Or some other things? I'm sorry? It's gooey? Yeah, it's very blood vessel rich, and you hit it, and it doesn't take much to get it to bleed. And then the last thing that I would add to that is, because it kind of sits on that stalk and it's fairly small, it can kind of swing around. And so it's easy for the spleen to be injured with a deceleration injury because it kind of swings around, bounces against the rib cage. So while as a general rule, people know when they've been shot or stabbed, blunt trauma can definitely have a delayed presentation. And in assessment, we'll talk more about the things that will help you pick up on that. Finally, I do want to mention blast injury, which is thankfully something we see fairly rarely, but I think that's part of the reason it's a good idea to review it in training. So with blast injury, you have a combination of blunt and penetrating mechanisms of injury. So the penetrating injury comes from irregularly shaped shrapnel debris, and so that can be something that was planned to do that, like in a grenade, or it can be improvised shrapnel, like in an improvised explosive device where someone is putting nails or whatever they can find into the bomb. You have, in addition to that, you have a pressure wave, which can compress the hollow organs, and it can cause contusion, or so it compresses the hollow organs. And then it can cause contusion or rupture, particularly to the solid organs. Because you both have this initial, you have the pressure wave, and then patients often get thrown with a blast injury, and then you have a secondary trauma. Remember that abdominal injury is definitely has life-threatening potential in blast injury, but the big hollow organ that gets injured in blast injury are the lungs because of that pressure wave. Any questions about any of that before we move on? So to recap anatomy and injury patterns, remember that the abdomen extends from the nipple line to the pelvis, that injury to the diaphragm can impact respiration, that hemorrhage, usually from injury to a solid organ, can kill a patient quickly, sepsis, usually from rupture of a hollow organ, can kill a patient late, and remember that retroperitoneal bleeding can be hidden and not show up on your abdominal exam. So let's move into talking about assessment. And I'm going to use the exam. So my conception of how to think about this is that in EMS, unlike with doctors, we are assessing both the mechanism of injury and the patient. And if you put a doctor in the field and ask him to assess the mechanism of injury, you'll get a lot of really different responses. It's not something that doctors routinely do, and it's our bread and butter in EMS. And then you're assessing the patient. So let me give you two case examples. So these are patients that I've seen within the last year. 21-year-old man who's brought in, he was stabbed in a bar fight. And then a 43-year-old woman who was moving some furniture yesterday and then passes out today. I'm going to ask first for the 21-year-old guy, what are the key items that you would want to get in your history and physical exam on this patient? So what was he stabbed with and where? What else? Yeah. How many times was he was stabbed? Figuring out the holes. What about for this 43-year-old woman moving furniture yesterday? Definitely possible. So just before you get to that point, what are some other things you'd want to know? Yeah. Okay. Medical history. She had a recent bout of mono. What are some other things you'd want to know? So this was about a month ago. No other treatment. She was just being observed. Yeah. So she's got a little bit of pain in her right shoulder. Nothing that really jumped out at her. There was one point where she fell down one step and hit her side against a couch that she was moving. She hit her left side against the couch. Yeah. Okay. So I think that's a good list, and we'll talk about a little bit more detail about the things you want to pick up on your assessment and how you can describe that. Okay. So you brought up a lot of the key points with penetrating trauma, knowing the length of the weapon. If you're able to find out, knowing what kind of assailant, I think it does make a difference. Was someone, was someone stabbed by a 17-year-old girl? Was someone stabbed by a 43-year-old veteran of 2 wars? That can give you some clues as to the injury pattern in terms of whether people are coming over or coming under, having the length. Having the caliber of the weapon can be helpful, but not worth taking much time on scene to figure out. So with blunt trauma, these are the things you do every day. Knowing whether they had restraints on and whether they had protective devices. So for a bicyclist, for a motorcyclist, for someone riding an ATV, were they helmeted? For a motorcyclist, were they wearing protective clothing? And then for someone in a car, where were they in the car? Knowing whether they were the passenger, which side where they were on, can help us predict which organs might be injured. And then for a blast, knowing whether there was shrapnel or not, getting some idea of what the distance thrown, with the distance the patient was thrown, can help the surgeons to predict the patterns of injury. So obviously you're going to do your primary survey and address airway and breathing, evaluate your circulation with vital signs. And I want to point out that if you are right at 205 and Mill Plain and you got someone who gets hit by a car and all you can figure out is, I've got a 20-year-old male who was hit by a car, he's got no radial pulse, he's got a carotid pulse at 100, and he's got head and belly trauma. That is all the emergency physician needs to know to get things moving. Now, yes, would we like vital signs? Yes, would we like other things? But knowing that we have a significantly injured trauma patient who's hypotensive, that is enough to get the trauma system moving and get things working. And that early notification with that basic information, just based on your primary survey, can get the trauma system moving. Then you're going to move on to your rapid trauma assessment. I think, as in our first patient, noting your level of consciousness and or signs of intoxication can give you a big idea as far as how reliable your exam is and whether there might be other injuries that are missed. You're going to expose and examine the patient, palpate the entire abdomen. Remember that the place that penetrating wounds tend to hide and get missed are in the armpits and in the groin. And those are not something we routinely see, but that's something that, particularly with an intoxicated patient, you want to take that extra second to look, because thinking that you have someone who has blunt trauma, but finding, oh, well, they actually had a stab wound to their axilla, that's something that can definitely change the course of that patient. If you're suspecting a pelvic injury, either because it looks deformed, the patient's complaining of pain, you do not want to test the pelvis. The idea with that is just, I've seen this happen in trauma centers where you're like, oh, wow, this pelvis is totally squished. And then someone's like, hey, look at this pelvis is totally squished. So the idea is that we want to limit repeat manipulation of the pelvis. Note the leg length, because that can be a clue as to pelvic injury. And then you complete your sample history and basic vital signs. I know that there's a real temptation either when you're a first responding agency or when you're transporting someone like that, you get a single low blood pressure. And I imagine you've all had this experience. You've got this guy, you got him in the back, and your initial blood pressure was 90/50, and then you get 10 minutes down the road, and you check your blood pressure, and it's 60 palp. And then you check it again in a minute, and you give them a little bit of fluid, and you're back up to 90/60. And I know that feeling. You're like, oh, man, it was loud in here. Did I really hear that, or did I really feel that right? Trust your judgment. The patient who starts at 90/60 and has a drop and then comes back up is very different from the patient who never had that drop. A slightly different situation, but especially if you're a first responder, you get to this patient and your first blood pressure is 60 by palpation, and then you get him packaged, you start IVs, and the first blood pressure that the transporting medics get is 85/40. That makes a difference. It's a different, I think in the hospital we tend to think, oh, here I've got this patient, he's got a blood pressure 100/60, things are all fine. But you are doing important things that can affect the blood pressure in this patient, and that single drop in blood pressure predicts bad things. And so patients who have that are much more likely to go to the operating room. So knowing, and you just tell the doctors what you found. You're like, his blood pressure dropped at one point. I gave him 250 milliliters of fluid, and then it came up. But that single piece of history is very helpful, and another place where EMS makes a big difference in the management of abdominal and pelvic trauma. So how do you describe your belly exam? This is my approach. You'll see other approaches, but I think this is a consistent and reproducible way. So you want to describe the appearance. Clearly, if their gut's hanging out, that deserves a mention. But there are other things that you might see, like a seatbelt sign or bruising across the abdomen. describing it as soft versus firm, describing it as whether it's distended or not, and then describing the tenderness. And this is my approach because it can be a little confusing and can be hard to reproduce between people. But I describe tenderness as either mild, moderate, or severe. And I recognize that that's subjective, but I think that as the longer we're in this business, the more we come to a general agreement about what that means. And if you find me in the emergency department, I'm always happy to press on a belly with you and talk about kind of how you describe that. So to me, mild is the patient like maybe winces a little bit. You just have to see, wow, did that really hurt you? Moderate is you definitely get some sense of tenderness when you press there. And severe is they're jumping off the bed when you touch that part of their belly. Describing the location where they're tender, whether they're tender all over or whether they're focally tender in one spot can be helpful to know. And then, has anyone heard the term a peritoneal abdomen before? So that's, you probably heard that phenomenon described if you're talking about someone with appendicitis. And you've probably seen it, if this is the patient where every bump you hit in the road, just hitting the bump drives them nuts, and it just gives them incredible belly pain. The other test that doctors will do for that is the heel tap. But it's just when you shake the peritoneum at all, it's so irritated that any jostling of the peritoneum causes them pain. So if you have any questions, so a peritoneal abdomen is something that often requires going to the operating room because there's generally spillage of either blood or the contents of hollow organs that's causing significant irritation of the peritoneum. And then the last thing that I would say is it's very important to describe the trend. Sometimes you're with these patients for upwards of 45 minutes. And so someone who started off with some mild epigastric tenderness and now has moderate epigastric tenderness and now diffuse abdominal tenderness, that's, that progression is very important. That's someone who's very different from someone who started off, well, you know, he had moderate epigastric tenderness and it's stayed about the same and it hasn't moved anywhere else. So your exam over time can be really helpful to the physician who's seeing this patient. Okay. So I'm going to repeat the question for people who are watching remotely. So the question is, what about retroperitoneal bleeding? Does it change when you palpate the back? And that's a very good question. And I think that's why I mentioned the retroperitoneum, because it's a lot harder to pick up on this. Occasionally, you might pick up some tenderness, especially in the paraspinal area. But a lot of times, these are patients that get immobilized pretty quickly, and it's not something that you can visualize. Occasionally, you'll see kind of a grayish discoloration, kind of bruising on the flanks, and that can be a sign for retroperitoneal bleeding. But that's part of the reason that I mention it and I break up those two areas, because retroperitoneal bleeding can be really hard to pick up on exam. And even for us in the emergency department, we basically need a CAT scan to definitively diagnose that that's where someone's bleeding, because the ultrasound doesn't pick it up. So where you're going to pick this up is your vital signs. These are patients who have significant retroperitoneal bleeding, typically show some abnormality in their vital signs. And if the pelvis is stable and the belly's okay, that's when the surgeons are going to be really worried about the retroperitoneum. Does that answer your question? Okay, so let's talk about atypical presentations, like that 43-year-old woman who passed out. So these are usually late presentations. You know, most of us can figure out, okay, this person fell 20 feet, this person got hit by a car. But especially in the elderly or people who have other reasons to be more susceptible to abdominal trauma, they can show up late. This 43-year-old woman had this recent bout of mono, so her spleen was was enlarged and more susceptible to trauma. But it was literally falling one step and kind of bouncing the left side of her flank off the couch. I had a 78-year-old woman who was walking, tripped, had a ground level fall, and she had a stable pelvic fracture, but had a pelvic hematoma because she lacerated one of those arteries with that trauma. And so these are patients, you can see significant abdominal bleeding, especially in the elderly, from relatively minor trauma. It can be particularly tricky in the elderly because they can be on Coumadin, which can make their bleeding difficult to stop, but they can also be on beta blockers, which can make it harder for them to show a vital sign response from that. And then you can, we all get a clue when we're palpating a belly that's really tender, but abdominal trauma can show up with signs outside the abdomen. So any irritation of the diaphragm can show up as shoulder pain. So then the classic one is pain from the spleen going up to, from bleeding around the spleen, irritating the diaphragm, going up to the left shoulder. That's especially the patient who's got shoulder pain, but like their shoulder moves around just fine. They're not having issues with their shoulder. But that can also, it can be referred up to the right shoulder as well. Back pain can be a sign of retroperitoneal bleeding. And some patients their back just kind of feels uncomfortable, particularly with a significant retroperitoneal bleed. You can have groin pain, especially with trauma from the kidneys. And you've seen this with patients who have kidney stones, this pain that starts in the flank, goes down towards the groin, can be a sign of an injury to the kidneys. Obviously, peeing blood's not good, and that typically catches some patients' attention, and that's something that you can pick up on your history, and occasionally may be the reason for the 911 call. And then, just remember, syncope, that 78-year-old woman that I had who had the pelvic hematoma. She looked pretty much like any other elderly woman who had hip fracture until all of a sudden she got diaphoretic and had a syncopal event. And that was the first clue to me, like, okay, I need to look for, like, she shouldn't be passing out just from a pelvic fracture. So to recap on the assessment, assess and describe your mechanism of injury. Do not discount your isolated low blood pressure readings. Describe your exam using clear, well-understood terms. And then be on guard for atypical presentations of abdominal trauma. Questions? Okay. Why don't we take 5 minutes now, and then we'll go on into management and then talk about pregnancy. Let's talk about management of abdominal trauma, because it's pretty impossible to give a lecture about abdominal trauma without showing a picture of someone with something sticking out of their belly. So in general, the management are things that we've talked about already. Rapid packaging, transport to a trauma center. Remember if there's blunt injury and you're concerned about spinal injury, then obviously these patients are getting immobilized. But penetrating abdominal injury does not require spinal immobilization, and these patients can be packaged in a position of comfort. You're going to be doing general shock care, and then there's specific care for eviscerations or impaled objects. So with eviscerations, cover them with a dressing that you moisten with sterile saline. You're trying to keep those organs from becoming dehydrated and from having any additional trauma. With impaled objects, your goal is stabilization. Why don't we remove penetrating objects that are impaled in the abdomen? Bleeding, and specifically why? How does that affect bleeding? I'm sorry? Yeah. You have to assume that as bad as things are, they could be worse. And so whatever is in there is in some stable form. And so this is not something, even a knife like this is not something that we would remove in the emergency department. That's something that's done in the operating room where you have everything available to intervene to fix the bleeding that can result from that. So you're going to stabilize the unstable pelvis. I would say when in doubt, when someone has either pelvic pain, unequal leg lengths, or tenderness with gentle palpation of the pelvis, you do not want to rock the pelvis, and you want to stabilize it. How many of you are carrying a commercial pelvic binder? So some of the agencies do have that. You can also use a sheet, and if you're using a sheet, then you're just making a knot, taking two people, pulling it tight, and then tying that down, and then making another knot, pulling it tight. And the goal of that is to reduce the volume where bleeding can accumulate in that pelvic space. Do not delay transport to get IV access. And you can begin fluid resuscitation. But remember, think back to those slides of blood. The people that we're taking care of are not bleeding salt water. And the IV fluid that we give them is not going to carry oxygen, and it's not going to help their blood clot. And this is something where, since I started my career in EMS, I think our thinking has changed quite a bit. So you do want to establish a large bore IV. I would say at least an 18 gauge can be helpful to give their fluid resuscitation. The military has gone exclusively to the 18 gauge just because it allows them simplicity in stocking, and it's adequate for the fluid resuscitation. People tend to have a high success rate with that. So your fluid challenge is typically going to be 1 liter or 20 milliliters per kilo for a child, not more than 2 liters of fluid for a trauma patient. And your goal is to get a systolic blood pressure somewhere around 80 to 90 millimeters of mercury. You're not trying to get these patients back to normal blood pressure. And if you say, I gave this patient 500 milliliters of fluid, their blood pressure is 82/60. That's completely acceptable. That's called permissive hypotension. And the idea behind that is that if we try to get their blood pressure up, especially if they have blunt abdominal injury, we're just going to increase the pressure that's driving that bleed. So our goal is to maintain end organ perfusion and then get control of the hemorrhage. Questions about that?
That end organ perfusion, we're looking at the systolic number that we're supposed to try to maintain. Should we look at the map?
In this case, I would focus on the systolic blood pressure, mostly because that's what's been, when we study, so the question was, is the systolic blood pressure or the MAP more important? And the answer is basically, when we study trauma, we study systolic blood pressure, whereas when we study sepsis or hypertensive emergency, we study MAP and have a better idea of what to do with that. I would also say trauma is something that's rapid, where your patient can change very rapidly, and a lot of the blood pressures that you may be getting are palpated blood pressures. So I think in this case, it's perfectly reasonable to target that systolic blood pressure and to just focus on that number. So to recap management, it's rapid packaging and transport to a trauma center, covering eviscerations with moist dressings, stabilizing impalements, and then fluid resuscitation to a systolic of 80 to 90 millimeters of mercury. Okay. So now let's move on to talk about pregnancy. So trauma is the #1 killer of pregnant females. Penetrating trauma is fairly rare, but very deadly in the pregnant patient. Of all the penetrating trauma, somewhere between 40 and 70% of that, depending on where you are gunshot wounds. We do know that incidence of domestic violence increases during pregnancy. Can I tell you exactly why? No, but we do know that pregnant women are at a higher risk for domestic violence. And then you can also get blunt trauma due to improperly worn seatbelts, and most of those are from auto collisions. But even with a properly worn seatbelt, you can have significant pelvic injury. I'm hearing a little feedback from the microphone. Are you guys hearing me okay in the back? Okay. So you have physiologic changes during pregnancy. You can think of pregnancy as the body getting ready for massive blood loss, because historically over time, many women have died in childbirth and had significant blood loss during pregnancy. So you have an increase in the circulatory volume. You have greater volume but fewer red cells. So the patients are relatively anemic. You have an increase in cardiac output to 40% by the 3rd trimester, and you typically get an increase in the heart rate. Particularly later on in pregnancy, it's not uncommon to have someone who has a resting heart rate in the area of 100 to 110. And then probably most important for our work, you have the uterus compressing the vena cava in the 3rd trimester. This gives you the supine hypotensive syndrome, where when the woman is laying flat, the uterus is laying right on top of the inferior vena cava, and so that's decreasing venous return. And you probably in your day-to-day lives, you don't see a lot of women in their 3rd trimester of pregnancy sleeping or doing anything else lying flat. And so when we potentially ask them to do that, we're risking making them hypotensive. The uterus changes dimensions throughout the pregnancy. And so this can protect abdominal organs. You see, so here's 12, 20, 32, 40 weeks. And the uterus is increasing in size during that time and pushing some of the other abdominal organs out of the way. But then this also potentially increases the danger to the uterus and to the fetus. The other thing that I think is important about this slide is just take a look at this 20-week marker. That's roughly, the fundus of the uterus is roughly at the level of the umbilicus. And so that's a rough marker on your assessment for fetal viability. Depending on which obstetrician you talk to and the capabilities of the NICU, generally between 24 and 26 weeks is when obstetricians will consider a pregnancy viable. So the key piece of your exam is just describing is the fundus above the umbilicus or below the umbilicus. If it's above the umbilicus, then that's someone who is potentially a viable pregnancy, potentially might need an emergent C-section, or in the case of maternal arrest, potentially even a perimortem C-section in the emergency department. So that's a key point in the assessment. So as you can picture, with the uterus getting bigger, the risk of something bad happening to the uterus or the fetus increases as the further along you go in pregnancy. Particularly with penetrating trauma, you can have mixing of the maternal and the fetal blood. That's not something that you need to address in the pre-hospital setting, but definitely something we'll need to address in the emergency department. And then from blunt trauma, you can have premature rupture of membranes. You can have placental abruption and uterine rupture. And these are roughly in order of how bad they are, and we'll talk about these individually. Premature rupture of membranes predisposes the woman to going into early labor and predisposes the woman to having complications from complications such as an infection of the fetus from having a prolonged rupture. And then we'll talk in more details about placental abruption and uterine rupture. So in placental abruption, you have a portion of the placenta separating from the uterus. So here's the placenta. And then here is the port where it's pulled away from the uterus, and you have bleeding collecting in this area. So this can happen from indirect or minor trauma. This can happen, particularly in someone who's predisposed, from something as simple as tripping and falling on her bottom. So it doesn't have to be direct abdominal trauma. Definitely can happen from direct abdominal trauma, as you might see in a car accident. Now, to get uterine rupture takes a significant amount of greater force. So in uterine rupture, the uterine wall itself tears open. So here's a point where you have the uterine wall tearing open, and you have the membranes bulging into the peritoneal cavity. This is frequently from a direct impact, takes a fairly significant amount of force. This is not something that you'll necessarily see on your exam because it's still, the uterus is ruptured but still within the abdomen, but it can be significant trauma. It's rare but possible to have particularly penetrating trauma where you're going through both the abdominal wall and the uterus, and you may be seeing fetal contents. So all of these things can present with abdominal pain, with uterine tenderness, with a gush of water, and with vaginal bleeding. So it can be difficult to tell based on your history what exactly is going on with this. That's part of the reason we have such a high index of suspicion with these patients. So your primary survey is similar to the non-pregnant patient. You're going to do your basic ABCs and stabilize those. The way that you protect the fetus is by supporting the mother. And then in your secondary survey, these are pieces of information that are helpful to get for the hospital. So asking about the number, the gravida and parida, the number of pregnancies and the number of births. Asking about the gestational age. Now, sometimes women will know this. Sometimes they may just know their last period, and you can estimate based on that. Sometimes they may know their due date. Any of those things you can use with a pregnancy wheel. If you don't have that accessible or you're doing other things, you can just give us, I have a woman who's pregnant, her last menstrual period was this date, or you can say her due date is this, and from that we can figure out the gestational age. Knowing whether she's had a previous cesarean section, particularly for someone who's critically ill, can help the obstetricians to prepare. And then some items that you can get on exam and history. If the woman is feeling vaginal bleeding after this, that's definitely something concerning. And then having the woman describe whether she's feeling the baby move. Later on in pregnancy, she may, after significant trauma, you may not feel the baby move. Now, you can have someone who's not feeling the baby move and they can still do okay, but having that additional piece of history saying, well, when she was with me, she described not feeling the baby move at all, and then 10 or 15 minutes in, she was feeling the baby move again. As we talked about, palpating the height of the fundus and then paying close attention to the vital signs. So how do we manage these patients? So left lateral recumbent because of the supine hypotensive syndrome. So if they're on the backboard, tilt the backboard. Who's done this before with a pregnant patient? How did that work? It's difficult. And what are the difficulties? Yeah. Maintaining C-spine. And what did you find the patient was just sliding off the board? What else? What other difficulties have you run into? Yeah, keeping them like that when you're driving. I mean, any bouncing can make it hard to maintain that position. So obviously that's something to think about as you're packaging the patient, that you may be tilting that. But one other alternative that you have, now this definitely takes an extra set of hands and it takes extra space in the ambulance, but you can have someone just displace the uterus to the left. And in the patient who, say, for example, is covered with blood or for some other reason it's just really hard, say, for body habitus, it's really hard to get on that backboard, that's another thing that you can do to deal with the supine hypotensive syndrome. So remember, you're going to give these patients high flow oxygen with the goal of getting their SATs to 100%. The reason for that is that the fetus is taking their oxygen from the maternal oxygen, and so having a very high concentration of maternal oxygen makes it easier for the fetus to get oxygen. And then just maintaining a very high index of suspicion for intra-abdominal bleeding. So to recap, pregnant women have different injury patterns. Supporting the mother supports the fetus. Shock, because of these circulatory changes, can appear later in a pregnant woman. You're going to give them high flow oxygen, place them left lateral recumbent, or if that's not possible, at least displace the uterus to the left, and then have a very low threshold for transport to a trauma center. Any other questions about pregnancy? And I'm just going to take a second to see if we have any other questions remotely. Looks like nothing else there. So let me wrap up. Okay. So I'm just going to put these slides up again. Just remember that these are patients with abdominal and pelvic trauma are at high risk for bleeding into the peritoneum, the retroperitoneum, or the pelvic space. We're trying to catch them before they get to this tipping point. That's our best chance of keeping them alive. And so early identification of significant abdominal injury, rapid packaging and transport, and then the specialized assessment and management of pregnant patients. Any other questions for me? Okay. I just want to make one last plea. Please do fill out the evaluations. I really value your feedback, and I thank you for your time. We'll get Dr. Whitwer in here, take a brief break, and he'll do his case review.
Each of these cases, I've already relayed this to the medics that were involved, so that because the intention of this is that we learn something, and also it's to partly to allow you to empower you guys to make decisions. I know you don't want to do that. You want to follow protocol. But what we're going to talk about is some cases involving STEMIs and activating the STEMI system, which during the day is not a big problem, but during the night you end up not only calling in the team from home and waking up the cardiologist and this, that, and the other thing. And the thing with our STEMI is I've done a review of the last 12 months of STEMI calls to the hospital, and we have taken less than 50% of those people have gone to actual cath lab and STEMI, which means that, and sometimes it's because sometimes they're older than I am. I mean, like really, really, really old people that don't really qualify for a STEMI. Sometimes, well, we'll see. We'll go through these things. Whoop. So, patients in a dialysis chair, awake, not responding appropriately. History of syncopal episode during dialysis. He's conscious and alert to himself and his birthday, but he says it's 1964. Well, that's not too far off. History of diabetes, renal failure, which of course is why he's in the dialysis chair, and hypertension. So, GCS is fine at the time, well, 13. Pain scales 0. Blood glucose 143. Supine pulse radial is 68. Regular. Blood pressure is ultimately palpated at 126. Got some naloxone for unknown particular reason, although at least it was a small amount of naloxone. 0.5. Just as another thing of to think. What do we give naloxone for? Okay, and what do we give the 2 milligram naloxone for? Yeah, respiratory distress, respiratory failure. You give it for apnea, you give it for hypoventilation, you give it for, but it's respiratory that gets the you know, that's what people die of from a narcotic overdose. So what do we give, what do we do for people who are on chronic pain medications? And they're not and they're not in respiratory failure. If they say, oh, they've got to change the altered mental status, you're going to check their glucose. And then how much Narcan do you give them? If you want to give them, you can either give them 0 or titrate the, you know. So on the case that we didn't put up today, the chronic methadone addicted person who got 2 milligrams of Narcan for his or her, it was a her, I believe, change of level of consciousness becomes violently agitated after getting this and begins biting and striking and hitting and doing all sorts of stuff, and goes into acute withdrawal. And your methadone folks will once in a while surprise you and have a seizure. And it's not pretty, and it's potentially really dangerous to them. So now, in this case, I don't know why he got Narcan. He had an altered level of consciousness, perhaps, because he had a syncopal episode, but there's no history that he was on chronic medications, narcotics. So, so think. Okay, 12 lead is put on. Suspected STEMI, anteroseptal elevation. Yes, 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 yes. Now we'll go and look at that. Okay. Now, what can you say about that 12 lead right off the bat? First of all, is it AMR's 12 lead? Is it Vancouver Fire's 12 lead? No. Whose 12 lead is it? That's the hospital 12 lead, because this is the first 12 lead I can find in the charts. Nobody gave me a copy of the 12 lead, so I can't back you up on whether this is. Now, what can you say about this patient's 12 lead? And you can all say about it. I need to find my pointer, and I don't find a pointer about here somewhere. I don't have a pointer, so okay. First of all, there is some ST segment elevation apparent in V1 and V2. I'll grant you that. And I'll have to say what probably was there on the AMR 12 lead or the Vancouver Fire 12 lead too. But what else is on this? Well, yeah, there's some peak T waves, yeah, and that might go along with his reason he's in dialysis, and that's one reason. And so hyperkalemia is one of the things you throw out that you say, I got a mimicker going on here. I can't trust the ST segment elevation. But what can you say about the R waves and the S waves in V1 and V2 and V5 and V6? They are pretty big. This guy has a history of hypertension, so he's got LVH. So automatically, you cannot trust. You've got a mimicker. You cannot trust your machine that says, "Oh, this is probably a STEMI," even if it says a STEMI. And by the way, it didn't, at least in the hospital, and they use the same machine. So this is a mimicker, and all you do is call the hospital and say, "Hey, I have an old guy who just had a syncopal episode at dialysis. He's got LVH. We're bringing him in code 3 if you want to bring him in code 3. And you don't have to call a STEMI on that one." So this is a mimicker. Final diagnosis: he had his vagal syncope, and he was hypotensive. His first blood pressure that you could get was only 128, which is not kind of normal for a guy who's got a long history of hypertension. He also had a little bit metabolic encephalopathy, probably due to his dialysis stuff, and leukocytosis doesn't mean diddle. So code 3 for a sick person is another one. Caregiver says the patient's increasingly weak over the past few days. And remember, you guys are taking history. We ask you to do a sample history on people. So, and the sample history not only includes signs and allergies and medications, but a history of things leading to this event. So this is an ancient guy. This is 90 years old. I'm going to tell you that most 90-year-old guys who are in a care facility, whatever kind of a care facility it is, most of them, even if they're having a heart attack, are not going to go to the cath lab. That's just kind of a given. He saw his PCP for epigastric pain, and 3 or 4 days ago, and was given Nexium. What's Nexium? For reflux and stuff like that, is the purple pill. He complains he's weak all over. He has pain in his groin. Now that's an interesting thing by itself, just because these guys don't have chest pain. He has pain other places. He denies chest pain, shortness of breath. 90-year-old sitting in a chair, alert, oriented, no distress. However, skin is cool, clammy, able to stand assist. EKG shows STEMI with elevation of V4R. Okay? So his blood pressure is 116 over 50, which is a little bit on the low end for an old guy. 92, pulse rate, et cetera, et cetera. Pain scale is 0, so he didn't get any medication. And there's his 12 lead. And indeed, he does have, and this is the note that I sent as a teaching note to the crew, this is clearly ST segment elevation. I do not argue that. It's perfect ST segment elevation. But look at the Q waves, particularly in 3 AVF. This is an MI, no question. But he's already developed Q waves. He's already had cardiac damage. He probably had his MI 3-4 days ago when he went to see the PCP, who's dumb enough to think that chest pain or weakness in an old guy with epigastric discomfort means he's having reflux. I mean, he probably didn't even do a 12 lead on him. So this one is another one that you call a STEMI when they're likely to go to the, I think your orders say 12 hours. The symptoms have been there for 12 hours, or you don't have any clear evidence of Q waves. In this case, I would say I've got a 90-year-old guy without chest pain. He appears to have a fully developed myocardial infarction. He has Q waves. He still has ST segment elevation in the inferior leads. His blood pressure is stable. He's not having any complaints. We're coming in code 3 with him just because we take people in code 3. Or might even consider taking him code 1. But just bring it and let them sort out whether they're going to do something with the cath lab. Talk to the doc, on the phone and tell them what you got. You don't have to call a STEMI. And when you think of these, this is not a mimicker. This is a real one, but it's too old to do anything about. Yeah. Well, yeah, except the Bluetooth won't transmit great distances. And we're still working, the hospital, they're still working at getting they're still working at getting the LifeNet thing, which is the new one that will transmit. It's a web-based transmission, so that would then take care of it. Except for places where you still can't transmit in the county. North Country is still up to making choices and things like that, and some places in Camas too. Okay. Upon arrival, staff reports patients with nausea all day. 15 minutes ago, complains of chest pain, substernal, non-radiating. Patient recently treated for an MI. Weeks. And if the history had been taken a little bit more aggressively at that point, yeah, she says, yeah, I went in 2 weeks ago, 3 weeks ago for an MI, for a heart attack, and they couldn't do anything. Okay. Semi-Fowler in bed, conscious alert time 4, skin pale dry. Monitor, she has STEMI, shows a STEMI and atrial fibrillation. Improved en route, just with some oxygen and stuff. And her blood pressure was 93 over 66. Rechecked, just about at arrival time, blood pressure is 92. Pulse rate's 150. Now, granted, we have time with this lady from 13:35 till 1400. 25 minutes. There's her 12 lead. What do you see on the 12 lead? Middling to wide, sort of what we used to call a incomplete bundle branch. It's a fairly wide complex, but she's got, what's her underlying rhythm? Pretty fast, but what's her rhythm? AFib. It's irregularly irregular, and I had to lie to tell you that there was any P waves there, so you know it's AFib. And it's pretty rapid ventricular response, though. And she has deep Q waves in 3 and AVF, just like the one before. She does have ST segment elevation, but we know that she has an MI just a few weeks ago, and they couldn't do anything about it. So does she have now what's known as a ventricular aneurysm, or has she got another MI where she had the first one? But she's had a previous MI. So this is probably not an acute STEMI with those Q waves. And her symptoms of chest discomfort, shortness of breath, are probably anginal due to a rapid rate. Her rate's getting her right now. She's in new onset AFib, and they slowed her rate down. Now, you could have done the same. Now, granted, and last week someone said, hey, wait a minute, Dr. Whitwer, she only has a blood pressure of 92 or 94. Yeah, but it's still close enough for government work. One of the reasons her blood pressure is low is because her rate's so fast. She's lost the Starling mechanism because of the sudden onset AFib. She's going to be in trouble. She's going to go into congestive failure, biggest bet on this one. So slow her rate down. How do you slow her rate down? Diltiazem is a good drug for that. And they did, and she got better. However, they already knew that they couldn't do anything in the cath lab because she went to the cath lab before, and they couldn't do anything and that was only a couple weeks before. So she went up to the PCU. She develops multi-dysrhythms. I mean, this is a failing heart. And she died. Now, we also didn't get a strip on this one. So I can't tell what it was. You know, I'm sure it was, and you wrote down it was, whoever did this said it was AFib with the rapid ventricular response. The crew did record a rate of 150. The ST was probably up due to ischemia. Previous MI rate should have been dealt with. Granted, there might not have been enough time, but we did have 25 minutes with the latest. She did get better with oxygen, but it didn't slow her heart rate any. And she very rapidly got treated with the diltiazem in the hospital. And sometimes the magic doesn't work, and they don't do well anyway. Okay, 57-year-old male, chest pain, states increasing pain over the last hour, took nitro ×2 with some relief. Pain starts in the right chest and radiates to the right bicep. Right-sided heart? Yes, right chest pain and right arm pain is just as big as left heart pain. In fact, in some instances, if you look at people with right-sided pain, they're more likely to have, that's more likely to indicate coronary artery disease. Now, if they have it both arms, it's even worse. He has a past history of a heart attack. Said it felt like this: conscious breathing, walking toward the ambulance, uncomfortable, pale, warm, and moist. Blood pressure is 152/102. He has a few PVCs showing up. 12 lead shows normal sinus rhythm and suspected inferior STEMI, and I believe he got a V4R in there as well. And this was his 12 lead. So his ST elevation in 2, 3, and AVF. Now, he has a pretty good Q wave in 3 and sort of intermediate, but he also has, you know, you can see the rest of this. I mean, he has extreme, I mean, this one goes with you, even with those few Q waves, which is probably from his previous MI. Now he's got acute ST segment elevation, and he's got marked reciprocals. So you can bet on this one. This one, you know, looks like, smells like a STEMI, and is. And indeed is a STEMI. He got treated well. He got aspirin. He got his fentanyl. He got nitro. He got stuff. They did a V4R, and he was okay with that, and he went off to bypass surgery because he had such extensive three-vessel disease, although he'd been stented in the past, that they couldn't stent him anymore. He had 3 vessels involved, and he started to fail, so they put in a balloon pump, aortic balloon pump, to keep him going while they took him off to open heart surgery half an hour later. And he did well, and he left the hospital, and he's in good shape with a triple bypass. Care staff states the patient alerted them that she was short of breath 1 hour before activation of EMS. They called her primary care MD for advice due to weakness and exertional shortness of breath, and he says, oh, bring her to the ER for evaluation. She had recent surgery on the left ankle. It's in a cast, and a sprain of her right ankle. What am I already thinking about this lady having? Skin is pale, warm, and dry. Moved from the chair to gurney. Noted a dramatic change in her breathing after a very small amount of exertion during the move. Moved to the MICU. The patient had a possible inferior STEMI. Transported K3 to PCEP. Well, blood pressure is 158. Pulse oximetry is 96 on room air. She is short of breath, so she could benefit from having some oxygen anyway. And this is her 12 lead. What can I once again say about this 12 lead? It's not yours. It's the hospital's. The first 12 lead I found in all of the charts, and we go through all of the charts. So she really doesn't, when you look at this, she really doesn't have any significant ST segment elevation. It was thought to be in the inferior leads, and she has kind of, what she has is, once again, a sort of incomplete right bundle branch block, which is probably right heart strain from her likely PE. And she got better when we treated her PE. You know, if it looks like a duck, quacks like a duck, it's probably. So we're throwing this up because this is part of the acute coronary syndrome cardiac triage tool that's in the that's the state of Washington legislature in their wisdom passed or approved, wrote into law so that it requires you guys to assess a person for the likelihood of acute coronary syndrome and then take them to the closest, highest level cardiac care center. This is in law, although there's no money in it to make it happen, which is typical of the Washington legislature. So patients enter the, you start thinking of acute coronary syndrome, and that's what we're going to, you know, we've been emphasizing STEMIs for a long, long, long time now, and so you're kind of, I think, overreacting to STEMI without thinking of acute coronary syndrome, because I want you to anticipate that even if your EKG is normal and the person has symptoms suggestive to you of acute coronary syndrome, that means that you need to repeat your 12 leads and repeat your go. But I also want you to understand that not all ST segment elevation is coronary. It's not due to coronary disease, and not due to an acute, it's probably due to coronary disease, but it's not due to acute myocardial infarction. So how you get it, you start using the triage tool by saying, is this person appropriate to consider acute coronary syndrome? Are they post-cardiac arrest with return of spontaneous circulation? That is actually written into the thing. If you have a cardiac arrest with ROSC, you take that person to a STEMI-capable hospital. And that's what you do almost 100% of the time. Or are they more than 21 years of age with symptoms lasting more than 10 minutes but less than 12 hours, suspected to be caused by coronary artery disease? So, and these symptoms could be chest discomfort, pressure, crushing pain, tightness, heaviness, cramping, burning, aching sensation, usually in the center of the chest, lasting more than a few minutes, or that goes away and comes back. Pain or discomfort in one or both arms, neck, jaw, shoulder, or back. Like that old guy's got pain in the groin. Shortness of breath with or without chest discomfort, epigastric stomach discomfort, like that old guy with unexplained indigestion, belching or pain. Other symptoms may include sweating. I always bet on sweating, diaphoresis. Nausea, vomiting, lightheadedness. Note, women, diabetics, geriatric patients may not have chest discomfort or pain, but they may have nausea, vomiting, back or jaw pain, fatigue, weakness, or generalized complaints. Okay. So, if they say yes, if you think yes, I think this is acute coronary syndrome, or you're working a cardiac arrest and they've now got ROSC, those patients immediately go to a STEMI-capable hospital if they're ROSC post-cardiac arrest, hypotension, or pulmonary edema, along with chest pain, shortness, etc. EKG positive for STEMI. We need to change this to white. Yeah. Well, I can't make it bigger on this thing. You guys, if you're watching this on on the GoToMeeting and you have an iPad, you can make it bigger and you can actually see it. The important thing, we just went through that assess immediate criteria. If they don't have any of those immediate criteria things, then you get into the triage of sorting out whether you think this symptom that they're describing is possibly due to acute coronary syndrome. You go through a risk assessment, and it's in your order, so you won't have to memorize this. Although it's So here's if 3 or more of these things are positive. It says 4. Age more than 55. That's 1. Then 3 or more cardiac risk factors. Family history, high blood pressure, high cholesterol known to the patient, diabetes, or current smoker. If any 3 of those things, that gives them 1 point. Aspirin use in the last 7 days. Why is that important to consider as a risk factor? It turns out through the TIMI trial, which was a huge international study, they found out that because we've done such a good job telling people, advertising to people that if they have chest pain, and it could be cardiac, that they're supposed to take an aspirin. That they have. So what this is a surrogate for the fact that the person's been nervous that he or she has had chest pain that might be coronary, so so any use of aspirin in the previous 7 days is thought to increase your risk, because it's a surrogate for your anxiety about your own health. More than 2 anginal events in the last 24 hours, including that current episode. So this is someone who's known to have angina, known coronary disease, ST deviation of only 0.5. If you have any of these other things, and you only have half a millimeter of that adds another point. So you're getting up to the 4 points. It's very easy to get 4 points. Almost all these people you talked about had 4 points. easy. And elevated cardiac markers, which, you know, some places in Washington are using the pre-hospital, they're using point-of-care testing for troponin. That's usually not positive for about anything from 2 to 6 hours after your MI, so it's not I don't think it's a real valuable thing for paramedics. So if you have four risk factors, then EMS personnel, you know, then you take that person to a PCI capable hospital, an advanced STEMI type hospital. So this then, this isn't really applicable for you guys because there are a few places in Washington where paramedics have to make a decision to go. A paramedic could take someone 60 minutes, can bypass a close hospital as long as a PCI capable hospital is within 60 minutes. That's still an okay thing. You don't have any issue if you think you have a STEMI, if you think you have acute coronary syndrome, they go to Peace Health Southwest because that's the 24/7, 365 PCI hospital. So, your protocol is pretty straightforward. If acute MI is suspected due to symptoms and you're going through history in a patient with active chest pain less than 12 hours, 12 lead EKG with ST elevation, and at least 2 contiguous leads, no left bundle branch block or paced rhythm, except if you have a left bundle with concordance, and you have to know what we mean by that. You have to be trained to that. And I've only found in the last 2 years, we've only found 3 cases that had concordance, so it's not common. Left bundle branch block is usually just left bundle branch block. And unless you took the patient in last week and he had a normal 12 lead, don't call a STEMI on a left bundle branch block. I've noticed that the machine is now reading very carefully. They're telling you left bundle branch blocks too. But they'll still say acute STEMI suspected. It's not too smart. No active bleeding, severe liver failure, severe systemic disease. They obviously get aspirin, nitroglycerin, analgesia as appropriate. If their 12 lead indicates an inferior MI in 2, 3, and AVF, only has to have 2 of those leads. Do a V3 and a V4R. That'll pick up about 90% of your right-sided MIs. Now, you can pick up 100% if you do an entire right-sided 12 lead. But that's a little time-consuming and a little bit redundant. If they have ST segment elevation in V3 and V4R, presumed right-sided MI, unless they are frankly hypertensive, they should not get nitroglycerin because they'll drop their pressure on you. Now, mimickers, benign early repolarization, generally young people. You see the ST, you've got some ST segment elevation in this one, very minimal, but it's between 0.5 and 1 in 2 and in 3 and in AVF I will not call. You've also got some ST segment elevation in V4 and V5 and V6, but you notice there's kind of a little squiggle at the end of it. That seems to be kind of an odd. I mean, those are 2 disparate areas to have STs. And it's not very impressive, and this happens. This is just early read. Saying, well, I think I have early repose. it's not ever very impressive ST segment elevation. You think a guy's having a young person really having a heart attack should have pretty decent ST segment elevation. Acute pericarditis. ST segment elevation in so many leads, you figure the guy would have to be dead. The chest pain is usually worse with swallowing, with movement of the esophagus. It's worse laying. They don't like to lay down. They prefer to sit up. And you can't have ST segment elevation in inferior, anterior, anterior septal, and lateral and still have someone be alive. Left ventricular hypertrophy. Well, I rest my case based on that first case. Left bundle branch block. Got a QS in V1, usually in V2 as well. And you'll also have either a broad R wave in V5 and V6, or obviously little rabbit ears. But the big thing is that big, wide QS pattern in V1. And there's no concordance on this. Concordance means the ST segment elevation has to be in the same direction as the major wave, the major QRS complex, and they're not. They're in exactly opposite directions, so there's no concordance. So left bundle branch block, if you're not sure, call them in. So I've got a guy with chest pain. He has a left bundle branch block, so I don't know if this is acute or not. That's what you bring him in as. Hyperkalemia. Big peak T waves. You'll also get ST segment elevation often with hyperkalemia. It's usually not marked like you do get with a STEMI until the patient gets extremely hyperkalemic and they start going to a QS instead of a QRS complex. But by that time, you should be able to figure they're in deep trouble. Ventricular aneurysms, if you've done if you have a person with a heart attack and you go through the normal healing process, the ST segment elevation should come back to normal within 2 to 3 weeks. If it persists, if you still have ST segment elevation 3 to 4 weeks after an MI, along with well-developed Q waves, that means you've got a ventricular aneurysm. So part of the wall of the ventricle is not functioning anymore, and it'll have that permanent ST segment elevation. That one might be tricky for you to sort out, except that with those big Q waves, you have to say, it's either, if the patient had new onset of chest pain suddenly at 4 weeks in, I bring him in saying, I've got a patient with severe chest pain. He's got he's got big Q waves in the V leads, the anterior V leads, and he's got ST segment elevation, but I think this is due to his previous MR. But we liked it so well, I'm going backward. Okay. All right, last thing. ALPS inclusion criteria. What do we do? What do we use the ALPS drugs for? Yeah. So in what kind of cardiac arrest cases do we use ALPS drugs? Yes. Persistent or recurring VFib and VTAC after one or more shock. That's the definition of persistent VFib or VTAC. Means they've had a shock and they persist with the VFib or the VTAC pulseless, and you then give them another shock and then give them drugs. So, and you also obviously have to have vascular access. We are going to be pushing, by the way, as part of our next month's thing, we are going to be doing a little update on the IO, because the preferred, for cardiac arrest, the preferred IO site now is the anterior, is the shoulder. So we'll have, that'll be part of our skills training for this coming month. And we will be putting in more and more of the big needles, which work anywhere. So with ALPS, remember, no open label IV amiodarone or lidocaine. Protected populations, prisoners, the usual suspects, prisoners, minors, pregnancy, traumas, etc. Those with a no study bracelet. Has anybody here seen a no study ALPS bracelet? I have not myself. Okay. What counts as a shock? Any shock delivered by an EMS agency, a first responder, AED, a PAD, a public access defibrillator, non-ROC agency shock. The police now, Vancouver police will be carrying, there's 60 or so AEDs that are going to be placed in the Vancouver police vehicles starting next month. They will be first responders when they'll be paged out when they're close to the site of the arrest. They will may be the first responders. We've already had 2 successful officer-administered AED shocks in Washougal in the last year, so that last within a month ago. The ICD, an internal defibrillator, does not count as a shock because we don't really know. Why do we know that? Well, the AED will not advise a shock unless they're in VFib or pulses VTAC. We know that over and over and over and over again. So if they gave a shock, that means they were in VFib. So that counts as your first shock. If they're still in VFib when you get there, then they're automatically qualify for the ALPS study. So study drugs should be given as soon as possible, within 10 minutes or less after. By and large, when you give it, you do give it within 10 minutes. So I think you're doing quite well. But you can, if you're in a hurry, if you have to get it in, you can give the study drugs literally together. So epinephrine, which is not a study drug, but if your first drug with recurring VFib is epinephrine, after your second shock, you can give the first doses of ALPS drug immediately after that, as long as you flush the tubing. Or you can wait till the next shock. If VFib, VTAC returns after you give the ALPS drug, carry out the full ALPS protocol. If you gave syringes 1A and 1B, which is your first dose, then you had ROSC, but they return with pulses VTAC or VFib subsequently, then you go back into it and give the next dose of ALPS drug. You shock again and then give the syringe 2. Anytime you get recurring or persistent VFib, VTAC, you treat it with the ALPS drugs, just because you would ordinarily treat it with amiodarone if we were in the study. So if you're transporting the patient and they, in the back of your rig, they go into VFib, you shock them, they stay in VFib, you shock them again, and you go into the ALPS protocol. First dose is 2 syringes, second dose is syringe number 2. So 1A and 1B count the first dose, syringe 2, except in the little itty bitty teeny weeny people. If you use up all your ALPS drugs, you can go to other antidysrhythmics such as magnesium, you can do more shocks, you can give more epinephrine, etc. You just can't use any open label amiodarone or lidocaine after you've done the ALPS study. If you break a syringe in the middle of things, then the patient's out of the study automatically, and you can go to your regular protocol and use either amiodarone or lidocaine as indicated. Now, we have had one recent case where ALPS 1A and 1B were given, and ALPS 2 were given, and nowhere in the sequence was the patient ever in VFib. Now that came to our immediate attention, and we dealt with that then. But this is, you gotta be in VFib or VTAC in order to qualify for ALPS. And it has to be persistent or recurring VFib or VTAC. Okay, and you have to use the ClearLink adapter because the stuff doesn't work otherwise, and you've been trained over and over and over on that stuff because it's not compatible with the lower lock system unless you use the ClearLink. Okay. Next month, we don't have a PCEP lecture. We have a skills session. Skills session will be packaging. We'll talk about alternate ways to package. Not everybody needs to be on a backboard, and we'll work on that one. We'll talk about using the new, the long